For joining this evening. My name is Cecilia Coccia. I'm one of the fellows at UCT, and Prof. Ali is just going to be overviewing the meeting. This evening, we've got 24 registrations from 8 different countries. Essentially, my presentation, I'm going to just give a bit of background, and then hopefully there's time for some clinical case discussions. So let me just screen share. And
that's all good. We can see that.
No, I'm just trying to now get the sort of, because oh, hang on. Okay. So we know that peptic ulcer disease is, sorry, I'm just struggling with something on my side. Okay, so peptic ulcer disease is essentially a discontinuation in the inner lining of the GI tract due to either gastric acid or pepsin. And essentially it needs to extend into the muscularis propria for it to be considered an ulcer. The ulcers can occur in the stomach and the lower esophagus typically, but can also occur in the distal duodenum or the jejunum. So there's 3 types essentially of ulcers. So we can classify them as either being H.pylori positive, they can be NSAID associated, or they can be H.pylori negative and non-NSAID associated. So then you're looking at things such as medications or toxins. So the main culprits are corticosteroids, bisphosphonates, potassium chloride or 5-FU. And then other factors such as alcohol, smoking, or recreational drugs. A hypersecretory environment must also be considered. So illnesses such as Zollinger-Ellison, systemic mastocytosis, cystic fibrosis, hyperparathyroidism, and antral G-cell hyperplasia. Malignancies can also obviously cause ulcerations, either primary gastric or metastatic disease. Acute stress, so especially your ICU patient due to decreased perfusion can end up with stress gastric ulcers. Viral infections such as CMV, vascular insufficiencies, radiotherapy. And we know Crohn's disease can cause ulcerations in the stomach, as well as chemotherapy. So in terms of the epidemiology, the lifetime risk for any individual for developing peptic ulcer disease is between 5 to 10%. There has been a decrease in worldwide incidence. So this is both due to improved hygiene and sanitation, due to the judicious use of NSAIDs, and then obviously due to H.pylori eradication. So we know duodenal ulcers are about 4 times more common than gastric ulcers, and they're more common in men than in females. But gastric ulcers, on the other hand, are more frequently a cause of bleed than duodenal ulcers, so 55% versus 37% essentially. And the mortality associated with peptic ulcer disease is about 5 to 10%. And usually that mortality is due to the comorbidities as opposed to the bleed itself. So just in terms of the pathophysiology, so your normal gastric lining, you essentially have defensive forces in place, such as your surface mucus secretion, the bicarbonate, your mucosal blood flow, your apical surface transport, and as well as your capacity to regenerate. And all of that protects against the damaging forces. So your normal damaging forces are your gastric acidity and your peptic enzymes. But once that's overwhelmed, either due to injury or to impaired defense, Injury being H. pylori, NSAIDs, aspirins, cigarettes. So what cigarettes do essentially is they not only decrease the mucus, they impair healing, and they decrease blood flow to the gastric mucosa, thereby causing injury. Then alcohol, gastric hyperacidity, and then if you have duodenal gastric reflux. And then your impaired defenses, again, is ischemia if you've got shock, if you've got delayed gastric emptying, and then other host factors. So as I said before, the peptic ulceration, you need to actually have it all the way down to the muscularis propria. As soon as you sort of lose your mucosal lining, the further layers are more susceptible to damage because you no longer have that protective barrier. So once you break through the mucosa, the injury is quite easy to go deep into the layers. In terms of the pathophysiology of NSAIDs, we know that you've got COX-1 and COX-2. So COX-1 is actually your protective, So when you essentially inhibit COX-1, you lose your GI protection from that. So you lose your mucus secretion, your gastric blood flow, as well as the platelet aggregation. Whereas what you preferentially want to inhibit is your COX-2, because thereby you stop the inflammatory process. You stop the prostanoids that promote edema, fever, pain, and healing. It's just important to bear in mind that both of them, however, do cause epithelial damage from topical irritation. And COX-1 inhibition also reduces blood flow, and COX-2 also increases leukocyte adhesion, all resulting in mucosal injury. In terms of the pathophysiology of H. pylori, we know that it affects up to 50% of the global population. It is a carcinogen as well as the strongest risk factor for non-cardiac gastric adenocarcinoma. And our eradication success is actually declining due to increasing antibiotic resistance. So this is just a small schematic. It's just to see how H. pylori affects the stomach, and it's sort of based on your host factors, the virulence factors, and the host immune response determines how the H. pylori affects the stomach. So almost 100% of individuals, or not, well, 100% of individuals end up with a chronic infection. 15% of these will get antral predominant gastritis, and that's essentially the pattern that ends up in a duodenal ulcer. And then your corpus predominant atrophic gastritis, that's what leads to gastric ulcerations, but also the pathway of intestinal metaplasia, dysplasia, and gastric cancer. Sorry, it's a very tiny slide, but essentially how H. pylori sort of affects the stomach is that there's three pathways. So it's colonization, immune escape, and then disease induction. So we know that urease essentially neutralizes the gastric acid, and the flagella help the H. pylori to move through the stomach. But then there's specific factors that actually cause specifically duodenal ulceration and gastric ulceration. So that's the adhesins, specifically BAB-A, which helps the H. pylori adhere to the gastric epithelial cells. And then you have CAG-A and VAC-A, which suppress phagocytosis, decrease the antimicrobial peptide. They induce tolerogenic dendritic cells, and they also suppress phagocytosis, and they block the affected T cell response. So CAG-A is also a proto-oncogene in a sense, because it causes quite a lot of downstream nuclear activation. And I'll show you the next slide where you can see how it sort of has long-term downstream effects. In terms of disease induction, specific factors are DUP-A, ICE-A, and then OIP-A, which again, having those factors in the H. pylori promote predominantly ulceration as opposed to carcinogenesis. So this is just a small diagram. They're not as nice as Dion's diagrams from Fellows Weekend, but you've got your H. pylori at the top with its flagella, And then you can see how the CAG-A, once that virulence factor is in play, it has a lot of downstream effects. And that essentially can cause things from cytoskeletal reorganization to growth factor expression, to apoptosis and cytotoxicity. And that it also causes hypergastremia, hypochlorhydria, and atrophic gastritis. So when you approach a patient with peptic ulcer disease, or any symptoms suggestive, there's often common symptoms and signs, and then obviously your alarm symptoms. So the common symptoms and signs is obviously epigastric abdominal pain. Generally, gastric ulcers present with pain 15 to 30 minutes postprandially, whereas duodenal ulcers present 2 to 3 hours postprandially. Bloating can be common, abdominal fullness can be common, there can be nausea and vomiting, especially in the setting of a gastric outlet obstruction. There can be either weight loss or weight gain. Generally, patients with duodenal ulcers end up with weight gain to suppress the pain that they get 2 to 3 hours postprandially. And then there can be hematemesis or melena, which both of them are obviously warning signs as well. So your warning signs are unintentional weight loss, progressive dysphagia, overt GI bleeding, iron deficiency anemia, and then recurrent emesis, which again may point to a gastric outlet obstruction, and then any family history of an upper GI malignancy. So your differential diagnosis can both be a local cause as well as a more systemic problem. So locally, it can just be a simple gastritis. It can be GERD. It can also be functional dyspepsia or gastric CA. Then pancreatitis can mimic. Biliary colic can be a mimic in cholecystitis. And then it's obviously just important to remember that things like a myocardial infarction, mesenteric ischemia, or mesenteric vasculitis can also present as peptic ulcer disease, or as a similar clinical syndrome to peptic ulcer disease rather. So evaluation, I'm not going to go into a lot of especially patients who present with an upper GI bleed, because Dr. Medise covered it quite extensively last week. We know that there's quite a lot of risk stratification tools. There's a Blatchford score, Rockwell score, AIM-65, etc. Just to bear in mind that these scores are predictors of a rebleed and death. And the most important thing is that the Blatchford score is really the only score that can tell you that you can safely discharge a patient if it's 0 to 1. All of the other scores are rather telling you sort of how severe it is or what the risk of rebleed and death is. In terms of evaluation, so gastroscopy we know is the gold standard. It has a 90% sensitivity and specificity. So any patient over 50 with new onset dyspepsia, or any patient with alarm symptoms, regardless of age, should undergo endoscopy if it's available. If, however, a gastroscopy is contraindicated, so if there's sedation risks, maybe an elderly patient with a high risk of aspiration, then a barium swallow can be done. If you look on the right, you can see a duodenal ulcer and a gastric ulcer on barium, and you basically just see the demarcated craters that the ulcer causes. Obviously, when you assess the patient, an FBC, LFTs, INR, UNE lipase, and serum gastrin may be required. It just depends on the clinical scenario. And then your H.pylori testing. So the serology and antibodies, as you know, if you've treated it or if you've cleared it, may still be positive. So the reasons you might do serologies in special circumstances, such as if you have a patient with acute GI bleeding where you might have a false negative RUT, or you may not have done a RUT at the time. If you've got severe atrophic gastritis, you might get a false negative if you've got multiple lymphoma or gastric cancer. So those are indications for possibly doing a serology. Your stool antigen is also a good test, but it's obviously cumbersome. It's quite difficult to get a fresh stool sample to a lab that provides it. I know our lab doesn't do it. Urea breath test, again, is the gold standard, especially for a test and treat strategy. But again, our laboratory, I'm not sure about other labs in South Africa or rather in sub-Saharan Africa that provide it, but unfortunately we don't have it available. And then you're right, which is what we commonly do. It has a sensitivity of 90% and a specificity of about 90 to 100%. What is important there is that it must be done off PPI for 2 weeks or off antibiotics and bismuth for at least 4 weeks. And then your histology should really only be done if you're looking at sort of going into the spectrum of antibiotic resistance testing, because it is quite a cumbersome process to do histology as an initial test. And then a CT and abdomen will be indicated if you're concerned about any complications of a peptic ulcer, such as a perforation or if there's an underlying gastric CA. So just looking at the forest classification, if you have a bleeder, so we know that it's classified from 1A up until 3, and the importance of the classification is just in terms of management and then also the risk of rebleed and mortality. So this is just a small algorithm that I took from a review article that Prof. van Rensburg wrote. So essentially, if you've got your upper GI bleed, you do a scope. If you've got a forest 1A or B, then you'll do dual therapy with epinephrine and either thermal probe or clip. If you have a visible vessel or forest 2A, then thermal probe or clip. And if you've got an adherent clot, you want to try and dislodge that clot after an epinephrine injection, and then sort of manage the bleeder with a thermal probe or a clip at that point. And then your two forest classifications where you can just treat the H. pylori if it's present and give a PPI is if you've got a forest 2C or a forest 3 ulcer. Sorry, it's a very, very small slide, but it's essentially just, it's actually from a pharmacology textbook, and it just shows the mechanism of action of all the drugs working on peptic acid secretion. So cimetidine and ranitidine, your H2 receptor antagonists, essentially they decrease CAM production, which then it stops the stimulation of your potassium hydrogen potassium ATPase. You've got your omeprazole, which works directly on the pump on the parietal cell. And then you have other drugs. So obviously your antibiotics, they directly sort of kill the H. pylori. What is important there is to just bear in mind how your gastric pH plays such an important role on the mechanism of action and rather the success of the antibiotics working. So when your gastric pH is less than 2, the half-life of amoxicillin is about 15 hours and the half-life of clarithromycin is only about an hour. Whereas if the gastric pH is pushed up to over 7, their half-lives are respectively increased to over 68 hours. And so therefore it's very important to ensure that when you eradicate, you do give an adequate dose of PPI and raise the gastric pH appropriately. You want to get it at a high pH as well, because that's when the H. pylori replicates and that's when it's more susceptible to antibiotics. Your bismuth compounds work in 2 ways. So they essentially provide a protective barrier, but they also dislodge the H. pylori from the gastric mucosa. And then your sulcrophate just makes a protective barrier at a pH of less than 4. Okay. In terms of the management, so the Maastricht consensus, which I think was published in 2020, was the last update. So essentially first-line therapy that they recommend is clarithromycin and a PPI. Obviously, it does depend on your various antibiotic resistance in your area of practice. If, however, you do have a more than 15% clarithromycin resistance with low metronidal resistance, then they suggest metro plus amoxil plus a PPI. If you've got low dual metro and clarithromycin resistance less than 15%, then you'll give quadruple therapy.
Cecilia, we lost you.
resistance in our center, which means ideally a chlorothiamoxil PPI regimen would be our best option for triple therapy. What's interesting is I came across the Japanese endoscopy guidelines for 20, and they advocating for vonaprazan, so the potassium channel inhibitor, as a first-line therapy with antibiotics, and only using PPI as a second-line therapy or when NSAIDs can't be stopped. Then just in terms of definitions, you can either get recurrent infection or you can get refractory infection with H. pylori. So your recurrent infection is when you have a positive non-serological test after an initial negative test following successful therapy. And that's usually due to intrafamilial exposure. So that's addressed by testing and treating family members. With refractory infection, it's essentially a positive non-serological test at least 4 weeks after pharmacological therapy. So just in terms of management of refractory H. pylori, so there's been a recent AGA clinical practice update that was in 2020 as well, just looking at the factors that play a role. So multiple factors. The one thing is intragastric pH. So host genetics play an important role. PPIs that are broken down by CYP2C119, so specifically omeprazole and lansoprazole. If a patient has that pathway that's abnormal, then those drugs don't essentially work. And unfortunately, omeprazole and lansoprazole are the two PPIs which we have readily available in state. Also need to look at the PPI dose, the frequency, and the potency. As well as co-administration with food. Then other host factors, smoking, age, other gastric pathologies. You want to look at your antibiotic dosing. So you want to make sure that the patient is taking it properly. You want to make sure that the dose is right and the frequency is right. And then if those things and non-adherence to treatment have been excluded, then you want to start looking at strain diversities and things like the virulence factors as causes. And then one of the sort of the third pillar of this triangle is the systems. And I think system barriers do play quite a big role. I mean, I don't think there's much in terms of research into our resistance profiles. And I think our support in terms of the drug availability that we have is also quite limited. So it's also an algorithm out of the AGA, just how to approach refractory H. pylori. So essentially, if you give a clarithromycin-based or metronidazole-based with amoxil and a PPI, and that fails, then your second line will be a PPI, bismuth, metronidazole, and tetracycline. And then failing that, I'm not going to go through the whole algorithm because nobody's going to remember it in any case. But then you start looking at drugs such as rifabutin and levofloxacin in combination with either metronidazole, amoxil, or tetracycline to try and get eradication. It's also important to bear in mind that if you've got an elderly patient with multiple comorbidities and at risk of infections, you also want to risk benefit weigh up whether it's worthwhile to give so many regimens of antibiotics in someone who's at very low risk of ulceration or gastric CA. Then this is also just a summary of all the international guidelines. In terms of failure, so it's your Maastricht, your Toronto, the AGA, and then the Chinese National Consensus Report. They didn't include the Japanese guidelines here, but it's just quite a nice slide because it covers everything. And again, this is all in the AGA practice update. When we look at NSAIDs, low-dose aspirin, and anticoagulants, the most important thing is the risk-benefit for patients. We know that with all these patients, the big problem is that you have to weigh up the cardiovascular risk or sort of the pain control in your rheumatoid arthritis patients versus the risk of upper GI bleed. So just a few things to consider. So there were a couple of pivotal trials. We know that in both Vigor and Class, that were both published in 2000, was shown that your selective COX-2 inhibitors were associated with a much lower incidence of ulcers and ulcer complications. So it's almost a non-brainer to use your selective inhibitors. In terms of clopidogrel, Eurlink et al. Showed that following an acute myocardial infarction, the use of proton pump inhibitors actually increased your risk of reinfarction as it lost the beneficial effects of clopidogrel. It is a very debatable topic, and there's been further studies, but it is something to bear in mind, especially when considering empiric PPI in someone who hasn't had peptic ulceration or hasn't had a bleed. And then we know in 2017, Compass was published that looked at rivaroxaban plus aspirin, and the combination reduced thrombotic outcomes in patients with atherosclerotic disease, but that ended up in a risk of major bleeding. So again, it just highlights the fact that you have to look at each patient individually, weigh up the risk benefit before you decide on anticoagulation, before you decide on NSAIDs, and then obviously counsel the patient regarding bleeding risks if they're present. So there are a couple of sort of algorithms that you can use when you look at putting a patient on NSAID therapy. I know that often we scope patients, we see ulcers, and we say that they need to stop all NSAIDs. But I think if you've got severe RA and you don't qualify for biological therapy, it's unfair to tell a patient to stop NSAIDs completely and to live in agony. So what's important is to just try and weigh up the risk benefit. So look at the risk of their gastrointestinal risk and their cardiovascular risk, and then you can weigh up which NSAIDs to use. So you can see on the far left, if you've got a high GI risk and a high cardiovascular risk with the patient already on ASA, you'll try and avoid an NSAID, but if you have to, then you'll give low-dose celecoxib with PPI cover. On the other end of the spectrum, if you've got a patient with a low GI risk and a low cardiovascular risk, then essentially any NSAID can be given, provided there isn't a reasonable indication. In terms of patients and bleeding and just when to restart anticoagulation, so this is from the ACC guidelines on how to manage patients on anticoagulants that bleed. So initially, you're going to look at if a bleed is considered major and if it's at a critical site or life-threatening. So GI bleeds aren't considered to be at a critical site, but obviously if it was a massive bleed, then you would consider it to be life-threatening. And at that case, you would stop your oral anticoagulants and you would initiate measures to control the bleeding. And if needed, you would reverse the agent. If it's not life-threatening, you'll stop the oral anticoagulants and initiate appropriate measures. And if you have controlled the bleeding, you then need to assess whether there is a clinical indication to continue the oral anticoagulant. So things that you would consider is if the patient has a high CHA2DS2-VASc score, if it was just a temporary indication for oral anticoagulation, it can actually be stopped. If the patient has recovered from a cardiomyopathy and it's no longer needed, if you've already been on anticoagulation for 3 months for a thromboembolism, or if you've got a bioprosthetic valve and not a mechanical valve, all of those things would make you actually consider stopping anticoagulation permanently. Whereas if you have to continue it, you would just look at sort of your bleeding risk factors again, and then decide on when you should restart it, whether it should be restarted immediately or whether it should be delayed. There are no firm recommendations on when you should restart it, but they have shown that if you restart it in 5 days, there's an increased risk of rebleed, whereas if you wait more than 7 days, then there's less thromboembolic events without necessarily increasing the risk of a rebleed. In terms of prognosis of peptic ulcer disease, unfortunately, there is a recurrence rate of up to 60% of peptic ulceration, regardless of H. pylori eradication. And then your perforation in NSAID-induced gastropathy is about 0.3% per patient per year. And in terms of complications, your main complications are obviously an upper GI bleed. You can get gastric outlet obstruction from fibrosis. You can have perforation, penetration, and then gastric CA. So that's essentially is my talk, and then I just have some clinical scenarios.
Cecilia?
Yeah.
Sorry. Before we go ahead with the clinical cases, can I just make a couple of comments, and can we ask the guys who would like to ask some questions? Okay, and then we'll go through your cases afterwards.
Okay.
Do you mind? Okay, I just have to make a couple of comments. Do you want to? I don't have control of your slides, so can you just go back to go back? No, next. Yeah, stop. Go. No, not so fast on the NSAIDs. Okay, that's okay. So on this slide, and I think you used the word we should use COX-2 inhibitors. The problem with both Vigor and with the class trial, they found that, remember, in class, 25% of the patients were given low-dose aspirin because they knew that the COX-2 inhibitors inhibit also aspirin, and therefore you have a high risk of developing coronary artery disease. So 25% of people were put on aspirin, and it negated the real benefit of the drug, and they cheated a little bit. So
Okay.
Vigor didn't use any aspirin at all, and more people died of coronary events. In the whole, COX-2 selective inhibitors are not that great drugs. And although they might negate the gastric ulceration, they have a higher risk of coronary events. So I think one has to be very careful. And then go on to your next slide. So yeah, this is where you put the GI risk, but you've also got a high cardiovascular risk. So one has to weigh up the cardiovascular risk versus the GI risk. And I think it's important that all of us should know that only Celebrex at 200 milligrams in a low dose in patients who have no cardiovascular risk, is it really worthwhile? Otherwise, the benefit of COX-2 inhibitors are not that great, especially if you're dealing with people who have cardiovascular risk, which is the majority of our patients with arthritis, because they've also got metabolic syndromes and they've got hypertension and coronary events. So normally what I teach our fellows is you have to have on your bedside, you have a Framingham score, and on the other side, you have the GI score, and you weigh these two up together. You pointed out naproxen there, and it's been shown that naproxen, even though it's a non-selective, seems to have the best benefit in reducing GI risk, but also in cardiovascular risk. So I still, this is my own bias. I still use the naproxen all the time with a PPI. I very rarely use a COX-2 inhibitor. Okay, that's my comment about NSAIDs. Then can you go to your slides about H. pylori? If you go back to the slide where you show how it infected the stomach. Go right up.
This one.
No.
This
yes,
one.
That one. Okay, so Cecilia, I'm going to ask you here, who needs eradication therapy here?
So, I mean, I would think that the patients with the corpus predominant that are at risk of gastric ulceration and gastric cancer are probably more important to eradicate. But I mean, even if you have antral predominant, there's still going to be a risk of multiple lymphoma. Okay. So the current guidelines are if H. pylori.
Let's not talk about guidelines. This is just between me and you and us. Because guidelines are made up by the same gangsters. Sorry. All right. So if you put a scope in and you find chronic infection there, you start off there, right? So yeah. You put a scope in and you find gastritis and you test the patient, and the patient is H. pylori positive. And I think this is for most of the fellows here. Are we all going to treat and eradicate that patient?
But what was the indication for the scope?
Dyspepsia, obviously.
I'm going to have to revert back to, because you can't call it a functional dyspepsia though until you've eradicated it. That's the problem.
Okay. So there's only 14% of people. What is the Kyoto? Please, for all the fellows, I mean, Cecilia mentioned all the guidelines, but probably the best paper is the Kyoto Consensus. And you'll see the same authors on the Maastricht are the same authors on Kyoto. It's this, they changed the first author. But anyway, it's this, that's why I call them the same gangsters. They belong to the same group. Anyway, but Kyoto is a much better. So if you take gastritis at an endoscope and you test them all and you eradicate all, only 14% of people will recover their symptoms and completely be healed. And that is what is called H. pylori associated gastritis or dyspepsia. The other 84%, their symptoms will recover again, whether the H. pylori eradicated or not. And that becomes the patients who have functional dyspepsia. So H. pylori associated gastritis is only a small number of people. And therefore, to eradicate the whole group, sorry, I can't, I don't have, can you guys see my pointer? No, no. That is on your chronic infection, yeah? Put your pointer on the chronic infection, Cecilia.
There.
Yeah. If you put it there and you take everybody and you eradicate them all, the benefit for dyspepsia is only going to be 14 people out of 100. And in 86, you're not going to gain any benefit from symptoms, which comes back to your eradication successful rate. And there's no doubt, and we've done, and many other people have done the studies. If you take virulent organisms and you take both the ulcer disease, which is on your top, and the bottom disease, which is the atrophic gastritis, if you eradicate those two groups of people, your success rate of eradication will almost be 95%. But it is the middle group. If you eradicate people that have got non-ulcer dyspepsia or non-atrophic pangastritis, those are coccoid bacteria, and they run away from bacteria, antibiotics, and they run away from PPIs, and they cause the most resistance to eradication. So my own bias, this is my bias, this is not the AGA or Maastricht. We never eradicate patients who have no ulcer or who don't have cancer, because only 14% will benefit from dyspepsia, which that is my bias. I'm not saying that's what you guys must do, but that is my bias. If you go on to the next slide on the pathophysiology, next one. Yes, no, go back. Yes, if you look at the bottom of the slide, right, on your right-hand corner, and I think Dion pointed it out very nicely at the fellows meeting, you get hypergastrinemia and hyperacidemia, and you get hypoachlorhydria. And in fact, those two physiological functions determine mostly what happens. So in your previous slide, in people that got antral gastritis, they develop a hypergastrinemia, they increase pepsinogens and they increase acid secretion, and they go on to develop duodenal ulcer. If you take the bottom part of the people who develop achlorhydria, they do not have hypergastrinemia, they get a pangastritis, everything gets wiped out, no acid, and they develop achlorhydria. So in fact, if you measure, and therefore one of the things that you had missing in your test, and I think in Kyoto points it out nicely now, if we're gonna do a non-invasive test where endoscopy is not available, we should be testing for H. pylori, and we should be testing for not necessarily gastrin, but pepsinogens. So if the pepsinogens are up, that means that patient have got increased acid, and they will definitely develop a duodenal ulcer. This was a dictum from Schwartz in 1910. Increase acid, increase ulcer. No acid, no ulcer. On the other hand, if you have H. pylori positive and you have low pepsinogens, this is the group that are going to develop achlorhydria and go on to develop cancer. So in fact, there should be only two kind of people that one eradicates: the one who have got more acid and the one who doesn't have any acid. And the middle, the majority of them, 80% of us have H. pylori positive and nothing happens to us. That's my little path on H. pylori. And on NSAIDs, please remember, selective COX-2 inhibitors are not God's gift to mankind. They kill more people. There's an interaction also with COX-2 inhibitors and PPIs, as Cecilia pointed out, especially in the first 3 months. If you're using a PPI and you're using Plavix, it dislodges it and it doesn't allow it to be inhibited, so the aspirin doesn't get activated, and therefore you can have a reclot. So I personally don't like COX-2 inhibitors, but I use neprilysin plus a PPI, and in H.pylori, I only eradicate those two kind of groups of people. Sorry, those are my little comments. Are there any questions from the audience? Cecilia, then we can show them the cases. Anybody has a question? Just go ahead, ask, unmute and ask. Nobody?
There's 3 questions
Prof.
in the chat. Okay, carry on, Mazamu.
Yes, thanks, Prof. Thanks, Cecilia. I just wanted to ask, or maybe ask for a comment on 2 things. The first is the utility of the gastropanel, excuse me, in such patients. And then secondly, cytoprotective agents. I know you mentioned bismuth, but then some of the others, and in what instances you may use these agents. Thank you.
Mzamo, have you got gastropanel available in your hospital?
Prof, no, to my knowledge, not widely available. I know that they have a couple of, they're running a couple of studies. I believe it's an empath, and some of the private.
Gastropanel will become available. It is the magic test. It is a blood test that tests H.pylori, Gestin, and pepsinogens. So, sorry, Cecilia, do you have any knowledge on this?
No, I actually don't, Prof. Sorry.
Yeah, it's a superb test. It's better than endoscopy. It will become the test for the future. It's just been validated. It was originally designed in Helsinki, but it's been worked out all over the world, and there's a lot of Peter Malvertheimer. The same crooks, the same gangsters are part of this. And even though I call them this, the gastropanel is what I really believe in, because as Dion pointed out a month ago, it is the acid which tells us where the patients are going to go. On cytoprotection, Cecilia, do you want to comment?
So, I mean, the only time it specifies when to use it is with the bismuth. There's no real guidelines on when sulcrafit must be used. And then I know there's also escabet, I think, which is only recommended in Japan. And that actually has an antimicrobial. It causes dislodgement as well of the H. pylori. But in terms of those 2, I'm not certain when exactly one would use them, as opposed to the bismuth that's as part of your second line therapy.
Sorry, for the record, there's no bismuth in South Africa. I'm not sure. Does anybody else? Can anybody else get bismuth in South Africa or in Africa? Anybody? No. So in fact, you see, Cecilia, which is interesting, that if they put second-line therapy or sometimes even first-line therapy, this has been published by Maastricht and Kyoto and the World Cup, and all of these people, they say this. First-line therapy, in fact, is quadruple therapy, 2 antibiotics, 1 PPI, and bismuth. And yet, in the whole of Africa, there's no bismuth available. So I mean, are they really telling us what to do? That is not correct what they're doing. So I don't adhere to it, and I don't even mention it, and I don't expect the fellow to answer it in the exam, because bismuth is not available. And therefore, I wouldn't expect him to answer it correctly. The neprilysin, sorry, Cecilia, the Japanese, remember the Japanese has been shown that they've got the cytochrome abnormality, and therefore they are rapid metabolizers. It's been shown that PPIs don't work so well in Japanese as opposed to Caucasians. And therefore they're using a potassium inhibitor rather than a hydrogen inhibitor. But in Africa, I mean, all of the guys in Cape Town showed in original studies that PPIs in black, white, colored South Africans work amazingly well. So do not believe that cytochrome story for South Africans. PPIs will inhibit our pH and elevate it to above 6. No problem with omeprazole, no problem with enzaprozole. We don't need vonoprazan. I know Takeda is now launching Dex in a couple of weeks' time, which is a pegylated moiety attached to lansoprazole, which makes it last longer. But I'm not sure that it really will be benefit to us. Anyway, so anybody else? Sorry, I took up all your time, Cecilia. Any other questions for Cecilia? No, the 19 participants are all happy. All right, Cecilia, we've got 10 minutes. So let's run. or see how many, and just give it to one of the guys to answer. Don't you answer. Show them
So
a case.
these clinical questions I've come up with because they're patients I've seen and I haven't really known what to do with them.
No, we'll answer the afterwards. But ask
so-
somebody. Ask
so-
one. Yeah,
So I'm
go
going
for
to
it.
choose. Okay, so the first case is just a 35-year-old male. He's a smoker. He receives eradication with amoxil, metronidazole, and PPI, which is what we currently have as first line and all therapy for gastric ulcer. He then has a repeat endoscopy 8 weeks later, and there's a persistent ulcer, and H. pylori remains positive. But our pharmacy doesn't have clarithromycin, and we don't have tetracycline. So I just wanted anyone's suggestions on how we manage this patient. And obviously we don't have bismuth either.
Okay, let's go for Zamo. He's on the line, so you answer, boss. Dr. Mbele.
Hi, Prof. Sorry, I just stepped out a second.
You're not supposed to step out.
Sorry, I just apologies. I just was answering on call, Prof. So this patient, you said 35-year-old smoker who's eradicated for H. pylori for a gastric ulcer, and then the endoscopy confirms persistent ulcer. I just think, for completeness sake, the first thing I'd confirm is that this ulcer is indeed benign.
Very good point, Cecilia. Did you have a biopsy?
Yes, so it was a benign ulcer.
Okay.
Very good point. Yes.
Yeah, particularly because it's a gastric ulcer. And then in terms of the Helicobacter, in terms of our axis, we also kind of our hands are tied. But if you think about the concomitant, or perhaps some of your other regimens, you didn't mention them, but your levofloxacin or your rifampicin-based regimens.
Before you go there, Zamo, would you ask the patient, has he been taking it correctly? For how many days did he take it?
Sure. Absolutely, Prof. Sorry,
Don't forget that, Cecilia. A lot of people tell you they're taking it, but in between they develop diarrhea, etc. And yeah, Ben says stop smoking, correctly so. But the first thing is, when you fail to eradicate, ask the patient, did he take it twice a day? And for how many days did you use your combo? 14 days or 1 week? Cecilia?
So we usually write it up for 10 days, the antibiotics, and then 14 days of BD-PPI, and then daily thereafter.
Yeah. Okay. So what I would suggest here, one is stop smoking. Ben is correct. I would make sure that he took his therapy twice a day. And in fact, you can double. What did you use, Losec or lansoprazole?
I think it was lansoprazole.
Okay, so 30 milligrams BD should be enough. But if you wanted to, and then of course you have to, if you need to eradicate this patient, which I think you need to, I would give him amoxicillin and give him a script to go buy his clarithromycin.
Okay, and if he can't afford the clarithromycin, I'm just, because this happens quite often that we get patients with refractory or recurrent disease, and we're very limited. And I know the guidelines.
If they have an ulcer, or are you talking about non-ulcer dyspepsia?
There've been a few with persistent ulcers.
I will tell you, if you have an ulcer, the GI unit has a kitty and you club together and you pay for the clarithromycin.
Okay.
If it's a non-ulcer dyspepsia, you send the patient home or can't do anything.
Okay.
Azithromycin, I don't think there's a lot of data on it. You have to use levofloxacin. That is probably, or if your hands are tied, then I sometimes use rifabutin.
Okay.
Together with the amoxicillin. But I think Ben is correct. This patient has to stop smoking. You have to make sure that he's taking his therapy regularly, and it should be for 14 days. Okay, let's move on to the next case quickly.
Okay, so 68-year-old female, she's hypertensive.
Ben, this is for you.
Hypertensive, diabetic. She has a STEMI, a non-STEMI. She undergoes a PCI. And it's an LAD obstruction, so it's quite a high risk non-STEMI. She gets abciximab because it's high risk, and then she gets discharged on dual antiplatelet. But 5 days later, she comes in with an upper GI bleed, and it's quite significant. She needs to be topped up. She gets IVI, PPI in the surgical ward. And when you scope her, you see a large Forest 2C ulcer. So essentially doesn't need intervention other than the PPI, and obviously you'll eradicate it. But just what do you advise cardiology, or what is the discussion regarding the dual antiplatelet therapy, seeing as it was quite a high risk bleed, and it's also a high risk stent for an LAD obstruction?
Simple answer, Ben.
Yes, Prof. Sorry, I'm talking from airport. I think, yeah, it's easy answer. I think just to sit with the cardiology and tell the cardiologist there is a risk and benefit, and sound seems this patient clopidogrel should be stopped, and as maybe continue the aspirin only wanting. But we have to sit with the cardiology and make a decision. It's a risk and benefit ratio first, because patient now here with a stent, and a stent high risk for thromboembolic in this patient. So they're going to continue with the Blivix or clopidogrel for a year. So your advice here to stop, go, make sure patient stable enough. I think we're going to go for scope once patient stable. And once you decided to see, and I'm sure you clump it there, and you advise them to minimize the anticoagulants. We cannot continue with the dual. From our side, dual anticoagulant is going to be high risk to recurrent bleed. So usually they are going to stop clopidogrel and continue the aspirin for this patient.
I don't think they're going to listen to you, Ben. So cardiologists never listen to gastroenterologists, but this is an excellent patient case scenario that Cecilia has put up here. The thing is, you have to weigh up cardiovascular risk versus GI risk. And this patient's got a high cardiovascular risk. There's no question about it. And there's no question that this patient needs dual antiplatelet therapy. So antithrombotic therapy, you all know, please be familiar with it. It's anticoagulation versus antiplatelet therapy. So I think in the guidelines that I'm familiar with, you can stop those therapies, you can heal the ulcer, but that patient will have to go back onto therapy. And unfortunately, Plavix is probably the safest one that we know about. And this patient will have to go back onto aspirin and Plavix, but you could probably prophylact with a PPI. My guess is you'd have to watch this woman like a hawk. Once she goes back onto dual antiplatelet therapy, put her on a PPI all the time. But the cardiologist will take over from you. And unfortunately, that's what will happen. What did you do, Cecilia, in this patient?
I think with this lady, we did what you said. We stopped the dual antiplatelet. I think it was for about 48 hours, and then restarted it with BD PPI dosing. Yeah,
correct. You cannot win this. Remember, this is an LAD. If this woman blocks up again and she dies, never mind the gastric ulcer. So I think the heart will take the first prize here. Okay.
They think that because this patient now, I know it's a controversy. Your PPI with clopidogrel, it's a controversy. Increase the
yeah, the highest risk is in the first 3 months. You are right. The highest risk of stenosis and interaction is in the first 3 months. So hopefully you pass the first 3 months and then you'll be okay after that. Cecilia, can we do one more case quickly?
Let me see which ones are okay. Yeah, so 55-year-old male with a metallic mitral valve on warfarin. He abuses grandpas. He can't live without them, and he presents with his third life-threatening upper GI bleed in 6 months. His previous scopes showed a Forest 3 incissural ulcer, and that ulcer still present with an adherent clot. So how do you manage this patient? And this is a made-up patient, Prof, so I don't know what happened to him.
This is a made-up, or this is not a made-up? Anybody wants to have a go? Who else is on? Sia, are you on the platform?
Yes, Prof, I am on.
Unmute and tell us what are you going to do?
Okay, I think one is the patient does need to be on anticoagulation, so warfarin or clexane, but you need to then explore if there is adequate insight in terms of knowing not to use grandpa or other NSAIDs, because they've had 3 life-threatening bleeds in 6 months.
Cecilia didn't tell us why he needs his grandpas. But
let's say osteoarthritis, he's got bad knees, Prof.
Yeah, what we used to do in the olden days is keep a grandpa put the powder, have a tin next to it on your desktop. Then you just put the powder into the tin, the top, and put a match on it. It ignites, it explodes. And once the patient sees this, you tell him, Baba, every time you swallow this is what is happening into your stomach. It's the best way to get him off his grandpa. But of course, in this guy, you're going to have to just keep on going, advise him on the best NSAIDs, which I think is naproxen, and then put him on a PPI twice a day.
Okay.
But in the end, I think what you showed us nicely in your last penultimate slide, you have to calculate cardiovascular risk versus GI risk. We are gastroenterologists, yes, and so we have to know that. There's about 6 criteria that makes up the GI risk, and then the Framingham score makes up the cardiovascular risk, and you then weigh the one up against the other. If the heart is the higher thing, you have to give into that and make sure they get dual antiplatelet therapy or anticoagulation or whatever they have, as you pointed out, the Chad Vesco, but you can protect at least nowadays with a PPI. Cecilia, thank you. I think that was very good, exciting, stimulating. It's common. Guys, these are your common bread and butter things every day of your life. H. pylori, NSAIDs, and GI bleeding. I've enjoyed it as much, and I hope you've enjoyed it. And thanks to Cecilia for organizing.
Thank you, Prof.
Good night, and thank you, guys.
Good night.
And Cheryl, thank you very much.
It's a pleasure. There's no meeting next week due to the public holiday. Just take note of that.
Okay, Cheryl, sorry, do we have to fill out the form now?
There's a feedback form in the link. You can just complete it, yes.
Okay.
Thanks,
Guys, don't
Mark.
forget to complete your form.
Okay, I'll keep it open for a few minutes.
Thank you.
Thank you.
Thanks, Cheryl.
Pleasure. Thanks, Cecilia.
Cheryl, where does it come up? The
It's
question.
in the chat. It's in the chat. If you just click on the chat, you'll find it there, the link, and you just click on the link.
There, Ms. Krishnan said.
Here we go. Okay, I think that's it. Can I close down the meeting?
Just hold on 1 second, Cheryl.
Still busy? Okay.
Sanjay is coming in on the 10th of May, eh?
Yes, I've heard of that. Yeah.
So he'll be in Johannesburg on the 10th, and then he's coming to Cape Town, meeting with a couple of people.
Mm-hmm.
And so I hope this goes well. Yeah.
Yeah.
Cheryl, thank you very much. I'm done. So.
Okay, I'm sure that's it. Thank you very much, Prof. Then we'll see you again. Thank you.
Right.
Bye.
Bye.